the traditional way in which we diagnose prostate cancer for the last 25 years has been men with suspected prostate cancer, either based on a raised prostate-specific antigen or abnormal digital rectal examination, undergo a 10 to 12 core transrectal ultrasound-guided prostate biopsy, which is a procedure in which a probe is inserted into the back passage and 10 to 12 cores are taken from the prostate from both sides. Now, we traditionally think that that test has some limitations in that it may miss some important cancer that needs treatment and may overdiagnose cancer that doesn't need treatment, which is the rationale for looking at an alternative way of diagnosing prostate cancer. So we looked at using an MRI scan to identify areas of suspicion within the prostate. With the transrectal biopsy or TRUS biopsy, you cannot see the areas that are likely to be cancer. You just take the cores from a regular sampling of the prostate. Whereas with the MRI, you can actually see areas which look suspicious, and you can focus your biopsies on those areas. So we were interested in exploring that pathway compared to the traditional pathway. So it was a randomized trial carried out in 23 centres in a number of different countries across the world. We randomized 500 men to either TRUS biopsy or an arm with multiparametric MRI. So in the MRI arm, men who had a suspicious MRI underwent a targeted biopsy with up to 4 targeted cores per suspicious area and up to 3 suspicious areas targeted. Men with a non-suspicious MRI underwent no biopsy. And we compared the proportion of men with clinically significant cancer, which we classified as Gleason 7 or greater, in each arm. We also looked at the proportion of men with clinically insignificant cancer, which was Gleason 6 in each arm, and we looked at the biopsy-related complications in each arm. We found that the MRI arm detected a greater proportion of men with clinically significant cancer, fewer men with clinically insignificant cancer, and men in that arm had fewer biopsy-related complications. So this means that if you want to identify men who are going to benefit from treatment, the MRI arm was better than the traditional TRUS biopsy pathway. So really, the group of patients that's precision focused on were men who had had no prior biopsy. So men who first present with suspicion of prostate cancer who are being investigated. And that showed that the MRI arm was better than the traditional pathway without an MRI in that group of men. So taking that together with the results of other studies such as Precision, the 4M study, and other work in men who have had a prior negative biopsy, in my mind, it supports the role of an MRI before a biopsy in all groups of men. So our current pathway is based on PSA or abnormal digital rectal examination, and there isn't a set threshold which determines when a man should get biopsied. More so, it's about the discussion of the risks and benefits of further investigation. And in terms of when a man gets an MRI or a biopsy after an MRI, I think that discussion is the same. It's about the risks and benefits of potential investigation and treatment should something be found that needs treatment. So you have to base it on the age of the patient, their comorbidity, and whether they stand to gain anything from diagnosis and treatment. So traditionally, MRI scans used to be done after a negative TRUS biopsy. Now, however, with the recent trials such as Promise and Precision, it does support the role of MRI before the first biopsy. So I actually would advocate an MRI before the first biopsy. We know that in men who have a biopsy, who go on to have an MRI, there is artifact from post-biopsy hemorrhage, and so the information is less useful unless you wait for a long period of time. So I would say before biopsy in all men. We know that targeted biopsy improves cancer detection rates for significant cancer, and how you do it varies. So the data from 2 main studies, the Future randomized controlled trial and the SMART target study, show that there isn't a significant difference in cancer detection between the different types of MRI-targeted biopsy. So my recommendation would be to use the local expertise at the centre that's available to them and use that technique. So this is something that's attracted quite a lot of attention recently, and it's because there have been studies that have shown that gadolinium does accumulate and deposit in the brain, and the MRI scan uses a sequence which involves contrast administration, which is the gadolinium, which is what could lead to accumulation. Now, the studies are not conclusive in the sense that there is no strong evidence that accumulation of gadolinium may cause adverse effects in humans. However, we know that it does accumulate, and there's a possibility of that. And the studies which look at associations, it's quite difficult to prove a causation of the gadolinium administration with a particular event, and whether or not that event would have happened spontaneously or whether it's associated with other factors is difficult to tease out. So the long and short of it is, when patients do have an MRI with gadolinium, it's important that they're aware that this is deposited in the brain, and we do not know what the long-term effects are, but we have been using this for a very long time without there being conclusive evidence of a deleterious effect. So I think the risks and benefits, in terms of weighing them up, the benefits tend to outweigh the risks at the moment. So I think one of the things that we showed from the multi-centre study was that MRI was superior to the trust biopsy arm, providing you had centres which had experience in performing the MRIs, reporting the MRIs, and carrying out the biopsy procedures. So I think this needs to be translated to your average centre, which means we need to see whether we can train clinicians to interpret and carry out the biopsy procedures to a high standard. In addition, we need to think about the capacity of centres to carry out more MRI scans, and certainly policy lobbying at a national or international level is important for that to be achieved. I think those are the two main areas that need to be explored. In terms of going forward, the MRI scan itself does take about 30 to 40 minutes when you carry out all three sequences, which is T2 weighted, diffusion weighted, and contrast enhanced. And whether that's feasible with the increase in capacity is a question that needs to be answered. And future research is looking into seeing whether or not the contrast sequence can be dropped from the MRI scan to create a quicker scan, which might take 20 minutes, but will allow a greater number of men to be scanned in the same time period with a lower requirement for staff, and that may be more cost effective.